your dosage increase and the patient will become tolerant. But it does show a little bit more in your bipolar patients. Again, that's why that one was circled there. Ziprasidone is another one that clinically we think of your bipolar patients will report sometimes more than your. I didn't circle that one on there, but clinically we sometimes do see that too. Okay. Risperdal now. So Risperdal, again, you'll notice when we're looking at schizophrenia, there's a little bit of the dose differences here as well. So we normally think of our average dose in bipolar patients. We're normally thinking 4 to 6 milligrams daily. And you don't really have doses above 6 milligrams that show a whole lot. They just really haven't been evaluated at doses above 6 milligrams in bipolar. Okay. You often can just titrate out at 2 to 3 milligrams daily. We normally look at Risperdal as a BID drug because of side effects. The half-life is 21 hours, so you can give it once a day. So that is sometimes just a medication you'll see given at bedtime, or sometimes a higher dose at bedtime, then splitting up to twice a day. You'll see lower doses sometimes in the morning. Don't forget that Const is still an option with this drug. Okay. So you often will start patients out right at 25 milligrams and go up to 50 milligrams if you need to. It comes in and does actually come now in a 12.5. But usually when we start out recommendations for bipolar, you can start right at 25 milligrams, 37.5 milligrams, and then 50 milligram syringes. So again, every 2 weeks, the dosing is the same as what you would see primarily in your schizophrenic patients too. Common side effects with Risperdal, again, with any CNS depressant, drowsiness, somnolence, we'd expect that. You may need to watch out for the orthostatic hypertension, and similar when we talked about it in schizophrenia. A lot of our, especially your atypical antipsychotics are known for potentially causing orthostatic hypertension. It can be dose dependent with Risperdal, so make sure you just watch out for that. Okay. The other thing with this drug, I had a doctor this morning that I need to have a conversation with. We have a patient, for example, right now who is on Risperdal, and we look at the common side effects of this drug, and he wanted to know if the patient was taking the drug or not. So instead of looking at the fact that we often have drugs that we can draw a drug level in, he wanted to draw a prolactin level and said the prolactin should be twice that of what it would be if he's actually taking the drug, which is not actually always true. Not everybody's going to have increases in prolactin, okay? The fact is that it's good to remember prolactin in Risperdal, right? It blocks that D2 a little bit more than some of our other atypicals, and you do have to worry about the gynecomastia and in men, some women might actually like that. I had a girl on the unit not too long ago that didn't want to stop taking Risperdal because she liked that effect. But remember, yeah, that does happen. It's, medication boob job, I guess. So most men aren't going to be happy about that, right? So that's where your prolactin issues kind of come in with this. There's not been anything to say, when this drug first came out, there was a lot of argument saying, well, just because somebody has high prolactin, that doesn't necessarily mean that they're going to have negative side effects from it. What it does come out to is it does show an increased risk of amenorrhea in women. It does show, the gynecomastia. It does show hormone irregularities, which are not good, right? So we want to try and avoid that when we can. So if you're noticing that they're having sexual side effects or any of those other hormonal imbalance effects from it, it's a good idea to get a prolactin level at that point, not to see if somebody's actually therapeutic, okay? All right. When we go into Zyprexa, so this drug, in terms of its utility in bipolar, despite the side effects, if someone is really manic, you will still see doctors using this because it does have some good sedative effects that we want to see acutely in bipolar. We hopefully don't want to necessarily see them again because of all the metabolic issues associated with it long term. But as an acute treatment, if you're seeing something that you want to look at as one of your heavier hitters that doctors are still going to recommend acutely, this comes into play. It does have approval for your maintenance therapy as well, but because of the side effects, you're going to see this used more acutely. Okay, makes sense? Okay. So common side effects, is, as we've kind of already touched on, the biggest one to make sure you're paying attention to is that weight gain. Average weight gain, they say, is above 10 pounds. It can be, especially in your children and adolescents, more significant and more rapid onset. Okay? I gave you guys that example of one of my patients that I was seeing that just in over a month, again, 32 pounds, not good. So the FDA has actually come out with a black box warning in children and adolescents specifically for that. Don't forget that. Higher risk for diabetes and hyperglycemia, and higher increase in children, especially for increased lipids. Okay? And then SYMBYAX, as I mentioned, is the combination of olanzapine and fluoxetine. So you'll notice here that it comes in a dosage that's not an exact equivalency to the Ziprasidone tablets. I'm sure Eli Lilly did that on purpose. But when you look at the dosages, the idea is a lot of doctors will end up just giving something close to that. Ideally, the studies were done specifically with these drugs showing that it did have benefit, especially in your bipolar depression patients. Again, because of the olanzapine component, still holds all those same risks as Zyprexa alone. Okay. So usually you're just going to start out at 6 milligrams and 6/25 milligrams of your Prozac, and titrate up to the 1250 if you need to. Okay, when we look at Seroquel again, really, really great if we're talking about bipolar 2 in terms of overall efficacy and studies that have been out there. Don't forget, if you remember your A to Z metabolic profile risk, that this does have the just under Zyprexa for your weight gain, your hyperlipidemia risk, hyperglycemia risk. Okay, so you want to keep that in mind when you're recommending Seroquel. Remember that metabolism by 3A4. The slide should look pretty similar to what you saw for schizophrenia. It's not too much different. Just remember that sedation profile. The one thing, if you remember nothing else in terms of drug interactions, is again, if it's given with phenytoin, it can increase the elimination of a drug up to 500%. So you are going to often need to give whopping doses of Seroquel, more than you would for any other rationale. Okay. We usually just don't like to have that combination because it's just not something that you can kind of guess where that's going to land at. And in terms of efficacy, it can kind of render Seroquel ineffective if you're on phenytoin. Okay? Questions on that? You guys okay? Good? Okay. When we look at the usual doses in bipolar, it's pretty similar actually to what we look at for our recommended doses of schizophrenia, where you generally are titrating towards 400 to 800, which is listed as, again, that FDA maximum dosage. Higher doses above 800 milligrams are generally tolerated with not a major increase in side effect profile. So this is, again, one of those areas where you may see doctors, if they show a little bit of benefit at 600 milligrams, a little more benefit at 800 milligrams, they want to potentially see, they may go above maximum dosage on this drug in your bipolar patients. And studies have shown that they've gone up to 1,200 milligrams without a major difference in adverse effects. So just so you can know clinically about that. I'm not going to throw that on as an exam question, but I think clinically it's good to know that don't always look at that max dose as that hard, fast rule. That there's studies that have shown, especially in Seroquel and bipolar, that they'll sometimes go up. Okay? Ziprasidone is another one. Just as I mentioned, I should say probably with Seroquel. Geodon, they do go up again to up to 240 milligrams a day. The FDA max dose is generally we think of as 160. So pretty much just can tack on extra 80 milligrams on their split. So you always want to give this again twice a day with food because of the bioavailability. You want to give it with food, and because of the GI side effects, you want to give it with food. Okay. It does have the 3A4 issues and the protein binding issues we already talked about. So remember I said if you want to try and lump certain drugs kind of similar with each other, the 3A4 issues and the protein binding issues and the food issues are similar with what other drug? We're going to talk about it in a minute. Latuda, right, I heard somebody say it. Okay, good. So the other thing with this drug that probably annoys more practitioners than anything else, but I think it's good to kind of still have it be in the back of your mind, especially as a pharmacist, is the QTC prolongation with this drug. Clinically, if you're on this drug and no other QTC prolonging agents, you probably don't have a whole lot to worry about in terms of arrhythmias and all that. The thing to worry about is that when you have two drugs that are QTC prolonging agents, okay? So just for good measure, you still should look at doing a baseline EKG and follow up after somebody's on a stabilized dosage of the drug just to make sure you're not having side effects. But most of the time, when you're going to see the issue come up with this drug for QTC issues, it's the combination of this drug plus another QTC prolonger. Okay? All right. When we go into this one, the only other thing I would probably say is this one, where we don't see it used as much in schizophrenia because you do have to go up to higher doses and it doesn't always have, it's not kind of thought of as one of more of those heavy hitters, okay, like I mentioned Risperdal and olanzapine sometimes is. This drug does work pretty well in bipolar. Again, you can go up to 240, but it does have a little bit more robust literature behind it to support its usage in bipolar maybe than it would have if you were to look at in schizophrenia, okay? Also, if you are looking at the metabolic issues, remember this is kind of on the lower side. If you're looking at Geodon, right, just above your Abilify, it's a little bit better in your metabolic profile. So less weight gain and hyperlipidemia is associated. Okay, so looking at Abilify, again, dose range up to 30 milligrams, 10 to 30 milligrams. Got a nice long half-life of this drug. You can dose it once a day. It is something, if say you don't want to look at the metabolic issues with Seroquel, it's still a good option. It is approved for atypical depression as well. So bipolar 2, it has some good validity for its use and recommendation. And when you're looking at it, there is some suggestion of this drug, specifically for those in the depressed phase, to use it for that purpose. And it can be especially used, again, without that fear for switching into mania with an antidepressant. So a lot of the times, this is a good augmentation agent instead of maybe using that antidepressant that a lot of times doctors will throw on board. It's a good suggestion. Okay? Okay, Saphris. Now this still has the same issues it had in schizophrenia where it's only available as an orally disintegrating tablet. It originally came out for acute treatment of schizophrenia and bipolar, okay, in the manic side. But it has gone through and shown it can be used as a maintenance therapy, similar dosing, 5 up to the maximum of 10 milligrams twice a day. Because it's an orally disintegrating tablet, again, it is a little more expensive, and you don't really see this used or recommended as much for that purpose because of that. Not that it's necessarily an ineffective drug, it's just orally disintegrating tablet, more costs, not often jumping to that as the first line option. Okay? And then Latuda. So again, this is another one you guys will probably see more right now in doctors' offices than others because it's the newest approved for bipolar depression. Drug companies are going around, and I've heard many patients talk about the samples that they'll get from their doctor. Okay, so you need to be aware of that's happening a lot with this drug. They have shown that the dose ranges, when they've done studies, have gone up to 120 milligrams a day. If we look at for schizophrenia, often you can start at 40 milligrams and sometimes stay at 40 milligrams. With bipolar, you'll see that the doses will go up again a little bit higher with this one. If you remember nothing else about Latuda, just remember that take it with the food because of the bioavailabilities we've already touched on today. Other common side effects you kind of see listed there, as you'd expect, where it falls in line with the Geodon class, your akathisia and your EPS are there. And again, the 3A4 is substrate. So similar, as I said, Ziprasidone and Latuda have some similarities there. And again, the protein binding is high on that one as well. Okay, so what is considered the mainstay of therapy in treating bipolar agents and looking at maybe in addition to that adjunctive therapy? So when you look at all the literature out there and you're looking at the mainstay of therapy for bipolar 2, what drug comes to mind? Actually not an antipsychotic.
Lithium.
Remember, we looked at our primary maintenance mood stabilizers. Maintenance, mainstay of therapy.
Lithium.
Lithium, absolutely. Okay? Lamotrigine kind of comes in after that as your second choice, okay? So lithium is definitely considered your mainstay of therapy in your bipolar 2 patients. And lamotrigine's got the most studies out there kind of showing that it has some benefit in it too. So remember, Roman numeral 2, remember, is your 2 L's, lithium, lamotrigine, okay? And then when you look at your adjunctive therapy, what else comes to mind? What's still got its claim to fame is probably your mainstay maintenance adjunctive drugs that go in addition to lithium.
Depo, carbamazepine.
It is
Lithium.
actually your other 3 that we think of for primary mood stabilizers. Valproic acid, sorry, the line was a little small, so I didn't write them all out. Valproic acid is VPA, carbamazepine, CBZ, and lamotrigine, LTC. Okay? So those are still looked at in terms of if you look at your overall recommendations and your mainstay of therapy, what the studies and the guidelines do suggest. Now, that doesn't mean that you can't go and use, again, your antipsychotics as augmentation agents or even as monotherapy. They do have that approval, but the studies still are supporting the drugs in that strategy as kind of your first line options. Okay? Which of the following mood stabilizing medications is considered appropriate first line in a patient with bipolar 2? Select all that apply. So what do you guys think? Is lithium?
Mm-hmm.
Yes. Lamotrigine?
Mm-hmm.
Yes. Quetiapine?
Mm-hmm.
Yes. And Latuda?
Mm-hmm.
Yes, but if you're thinking first line, your 2 L's, right? Lamotrigine, Lamictal. That's your first line when we're thinking of those that have the best efficacy. So yes, they can all treat bipolar 2, but lithium, lamotrigine. Okay. As I mentioned before, all of your antipsychotics can be used, right? We know that. We always are going to remember your augmentation agents of your benzodiazepines. The vast majority of patients, yes, we absolutely, because of the substance abuse issues, because of tolerance issues, we're going to generally get them off those drugs. I don't want to say you never see somebody that just does really well while they've got that Klonopin or that stays on that at bedtime to help them with the sleep and everything else. But again, you really do want to think about those more as your adjunctive agents. In terms of if you have somebody who would like to get pregnant and looks at the risks of the drugs and aren't incredibly happy with them, Latuda, interestingly enough, in your bipolar 2 patients is a category B, but there is not a ridiculous, robust amount of evidence behind that. It hasn't shown in what we know at this point any sort of teratogenicity, and it has shown in some pregnancies it's been safe. But a lot of people will still think of going a little bit more of the old school method of calcium channel blockers, and nimodipine is sometimes recommended. And nifedipine is sometimes recommended, so most people will think of Cardia, which is nifedipine, as kind of your pregnancy drug. They actually use that in certain pregnancy situations to slow down contractions, so you may want to kind of remember that if you are treating someone with in their 3rd trimester, but it is overall looked at as a safer drug than some of the other options that are out there with our antipsychotics and our manic agents, your anticonvulsants, and lithium, okay? That being said, when we're looking at our other agents, sometimes we'll see clonidine and propranolol that can help out with a lot of more of the anxiety and anxious symptoms that patients will report. So pretty much as adjunctive agents, I'm not looking at them as overall mood stabilizers, okay? But they're very commonly used, don't really have substance abuse issues with them. And there's some literature behind showing that they have benefit as augmentative strategies to use in patients that, especially with anxiety issues. Other anticonvulsants, I don't want you to see this and think of gabapine or Neurontin, topiramate or Topamax, and tiagabine, brand name Gabatril, okay? I list them up there because they're inappropriately used as mood stabilizers. Enough literature has been clearly documented that they are not preferred agents to treat mood symptoms. Okay? Of all of them, oxcarbazepine, again, the one that's similar to carbamazepine, just kind of more of that purified version of the drug with less side effects you don't have to worry about. Basically, oxcarbazepine is much, much, much less of all the side effects of carbamazepine, with the one exception of hyponatremia. It's got a higher incidence of hyponatremia than carbamazepine does. But otherwise, you can think of it as don't need to plasma monitor, less hepatotoxicity issues, less blood dyscrasia issues, less liver issues. As a whole, it's a safer drug. So a lot of times, instead of just going to carbamazepine, a lot of physicians will look at using trileptal as an alternative agent. There is some literature supporting it. There's not enough where it's come out and gotten like an FDA stamp on that, okay? But there is still studies kind of in progress that are specifically looking at trileptal as potentially a good agent, and there are some studies that have actually shown that it should potentially get into our recommendations. It is actually listed, I believe, in DiPiro as well as an option. Not FDA approved, but has evidence behind it for supporting its use, okay? All right. The other we talked about early on is electroconvulsive therapy. Again, I'm not jumping to that as our first line option. It's kind of when other agents have failed. And looking at the conclusion of all this, is there a perfect mood stabilizer? No. You'll notice that even in our most effective, when we're looking at lithium, okay? So overall, 70% effective for acute mania, maintenance, pretty good at decreasing cycles, having some prophylactic abilities. That's not 100%. We know that. The big thing is paying attention to your patient and their current things. You want to treat the symptoms of the illness, not look at it as a disease, not look at it as a disorder. Treat that current patient's symptoms because everyone is still going to present differently. Okay? There's various levels. There's people that are going to have mixed presentation and are not able to hold down a normal job because their mood is so labile and they're all over the place. And then there's other people that might only have one hypomanic episode and in general it was pretty mild. And you don't have to necessarily treat that. Okay? So you have to recognize that this is a big spectrum, the same as you would talk about depression. Okay? So that's really important to keep in mind. There's not one med fits all, same as we've talked about with other disorders across the board at this point, right? Okay, and then the others that we need to look at, the other thing is that this is, again, one of those options. If I were to say, you know, polypharmacy, what disorders are polypharmacy potentially recommended in? Bipolar can come into that, especially when you look at your acute medications that you are going to recommend on board. You're going to look at that antipsychotic. You're going to look at potentially if they're severely depressed. You can still recommend an antidepressant. You can look at, you know, the anxiety options like I just mentioned, clonidine or propranolol, okay? Always looking at that baseline mood stabilizer as our number one recommendation, right? And kind of going from there, right? Okay. The other is that you have to consider those benefits and risks. We talked about some serious side effects with lithium, serious side effects with carbamazepine and Depakote, and some serious side effects with lamotrigine. All of our antipsychotics, we know, have them as well. We spend enough time in schizophrenia and the metabolic issues and all that. So you really do have to weigh the benefits versus the risk and that particular patient's issues. The patient really needs to be involved in making your informed decision and needs to be part of their treatment. There's going to be patients that might not have a whole lot of insight into their illness. And, you know, it might take them a couple cycles and losing jobs or money or relationships to get them to recognize that medications are out there and can help them. And then there's others that, again, might say, okay, I don't want to worry about the risks of what can happen with this disorder and go on it. Remember that if it's just one hypomanic episode, if it's a bipolar 2 patient that's only had one hypomanic episode, how long do you wait to potentially discontinue therapy? Talked about it earlier. 12 months, right? So it's still advisable to go 12 months to try, and the idea is to try and slow down if there's going to be a cyclic effect that you want to slow any type of progression down. So that's why we still recommend a year, even if it's one hypomanic episode, okay? But still recognizing you're treating the patient. So if the patient is able to manage things and make that informed decision, that's completely fine if they're able to know and still have insight in their illness and recognize at that point. All right, so I always like to wrap up going back to thinking about our case. So looking back at DE, our 27-year-old white male brought into the psych ER by the police, being found walking barefoot near Back Cove, claiming he was God and could walk on water. He made sexual advances toward the female police officer and the nurse in the ER. Has pressured speech, appears to be thought blocking for auditory command hallucinations. He's disheveled and malodorous. He was reported to be awake all night despite being given 2 ETOs. And reviewing his med records, you see he was treated outpatient for a major depressive episode 6 months ago. So we kind of talked about some of the questions before, but if we were to look at what you would expect to help at this point in time. So give me exactly what you would do as a pharmacist. What's probably the first medication that's kind of jumping to mind at this acute period?
Risperidone.
Risperidone? That's not a bad option, sure. One of your approved antipsychotics for mania, probably, right?
Yeah.
So our antipsychotics that are going to specifically address a psychotic effect, bring them out of that manic state. Is risperidone okay to kind of go on and if you have a good symptom response, stay on, or would you recommend, in this guy, would you recommend another maintenance med? You recommend something else? So the literature does support that we should be looking at first line our lithium, Depakote, carbamazepine. And the thing is the key is here, he's having his second cycle within a year. So that clearly is telling you that we want to be concerned that he could slip back from a manic side back to a depressed phase, right? So we want to be careful on what we're going to give him and try and make sure we're stabilizing his mood, right? So it's not a bad idea to look at treating with one of those and then maybe tapering off the Risperidone. I still wholeheartedly mean when I say the patient needs to know the risks. Patient may not like the risk of lithium, carbamazepine, lamotrigine even though it's pretty safe as long as you dose it the right way, okay? I say that because that's when you run into problems with lamotrigine and you see all those numbers come up. Those aren't always people following the dosing parameters that the starter pack and that the manufacturer recommends, okay? You dose lamotrigine, you dose lamotrigine, generally you're supposed to, it is a pretty safe and effective medication. But yeah, say he doesn't like those options and he responds to Risperidone. Risperidone is approved as a monotherapy for bipolar. But keeping in mind that it may not be enough to kind of keep him out of depression later on. That's why we like our other options that we've discussed already a little bit better. What are the most appropriate treatment options at this point? If I were to say, you know, he's starting on your maintenance med and he's starting on an antipsychotic, is there anything else that you could think of recommending at this time, or is he good? What do you think? Any other augmentative medications you might think about? I will tell you, in most of your patients that come in having hallucinations and showing, especially with the hypersexuality, most people aren't really fond of that, okay? They'll probably throw a benzodiazepine on board with this guy to kind of calm him down. The other thing is, and it's interesting that I love the fact that Risperidone came out, because people like the idea, maybe it'll increase his prolactin. Maybe that'll slow his butt down a little with the hypersexuality, right? We don't want to always treat with the side effect to help out what we're looking for, but that does happen. I've had doctors that have specifically gone and picked drugs to help hypersexual behavior. Back when I was at the state hospital, we had a high forensic population, and you would see time and again in those hypersexual predators that were admitted to the hospital that clearly had mental illness too. They loved Risperidone and Prozac. Why?
Sexual dysfunction.
CYP2D6. Not only that, so Risperidone and Prozac is a 2D6 inhibitor, doubles the concentration of Risperidone in the body, right? Risperidone by itself increases prolactin to decrease sexual drive, right? Prozac decreases sexual drive. SSRIs also have some potential effects even on prolactin a little bit, okay? And decrease sexual drive. So that's actually, if you're talking about the right forensic population, you'll see that on board sometimes, okay? Not something I would endorse in most patients, but that's, again, you got to treat the patient in the situation, not just one size fits all. Okay, so if you look at that plan as a whole, again, it kind of goes back to the summary slide I just hit. You're often going to look at 3 or 4 agents in an acute period, and then the idea is then you want to try and taper them down to monotherapy. Okay, you're not looking at 3 or 4 drugs for the vast majority of patients that have had one cyclical episode. And even again, if he's having some anxiety symptoms or something like that, you can look at your propranolol, your clonidine, other augmentative strategies. Okay, Any questions? I love huskies. I had 2 of them. They're like my favorite dogs on the planet.
So cute.
They always have like those inquisitive faces. Any questions, you guys? Was there any other muddy points that you guys want me to touch on right now? And I will be doing, I just found out we didn't get the room in the pharmacy. I will be here at 5 o'clock for the review. I'm probably going to do most of, because I am 85 to 90% done with the exam. There's a couple questions that I'm going and adding from what we've talked about in lecture. My questions, I say this wholeheartedly, I mean it. I've said it before, I think, but my questions come from my lectures. I'm not going to pull it out of some obscure table. I had a professor, my psych professor, I'll throw it out there, okay, that specifically asked something that was at the bottom of a chart in DePiro that I wanted to walk up after the exam and I'm not a violent person, but I wanted to smack him. So I will never do that to you guys. It will be strictly from my notes and what we've talked about in lecture for questions. So I'm going to come in at 5 o'clock, and whenever we kind of wrap up with questions, we'll be done. Friday will be a little bit more of a focused review for like my normal review session that I always do before like an exam, where if you have questions on specific focus points, I can speak to a little bit of that today, but I will hone in on that a little bit more if you're looking for specific areas within lecture, okay? You guys good? No other questions? Good. Okay.